So because of the timelines and because of the impact of age and fertility, if you have a fibroid that we know is impacting implantation, you can still do IVF, take the eggs out, make embryos, freeze embryos, and then worry about having the myomectomy or the fibroid removed and doing an embryo transfer down the line without having, quote unquote, wasted those precious months or years that it takes to carry forward with a myomectomy and the recovery. Every once in a while, a fibroid can actually have an impact on the access to the ovaries. Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as our baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together. Welcome, everyone. Today, we're going to be talking about fibroids and fertility. We're going to answer your burning questions such as, what are fibroids? Why do they matter for your fertility journey? How do you know if you have one? What are the type of fibroids? How do you get rid of them? Pretty much everything in between.
And this is such a high-yield topic. This is like the bread and butter of our day-to-day, right? Because we see fibroids all the time.
Oh yeah, they're super common.
Mm-hmm. We know that by age 50, up to 70 to 80% of women will have developed fibroids. Even though many may not even experience symptoms, we know that they're there and we can see them on ultrasound.
Okay, let's start with what actually is a fibroid. So a fibroid is essentially a tumor of the wall of the uterus. The uterus have an inner layer, which is the glandular layer. That's what sheds the menstruation. And then it has a muscular layer, which is where fibroids come from. So the word tumor sounds awful, but I think it's important to know that most fibroids are completely benign. They're not cancer. There is one subtype of fibroids that is cancer. They're called sarcomas. Those are extremely rare. And we're not going to be talking about that bad stuff today.
Mm-hmm. Jill, actually, when I was a resident, I did a research project on exactly that, fibroids and sarcomas. They are extremely rare. I remember trying to find cases as I was doing a chart review, as you do as a resident. Mm-hmm. And it was a struggle. I went through a lot of charts.
Another common question that comes up with fibroids is, what causes fibroid? Where do they come from? And the answer to that, really, it's not very well understood. Some people believe it's related to inflammation. Other people believe it's related to hormonal issues. We do know that fibroids have estrogen and progesterone receptors. So there's definitely a hormonal component to fibroid growth and development. But the actual mechanism is not very well understood. We do know that genetics plays a big factor in fibroids. So there are certain people who have a high predisposition to developing fibroids versus others.
And age matters too, right? So when we're thinking about fibroids, we know that the likelihood that somebody's going to have a fibroid goes up as their age goes up. And so we see them most commonly in women in their 30s or 40s for premenopause. But then what's interesting is that because they're growing based on estrogen progesterone, once women hit menopause, fibroids will often shrink.
Fibroids can vary greatly in size. They can be tiny 1 to 2 centimeter fibroids to massive, gigantic 20, 30, 40 centimeter fibroids. I bet that you're never going to guess, Dr. Wise, what is the largest documented fibroid in history? Give me a number.
Well, thinking back to being a resident, I think the largest fibroid I ever saw was probably 15 pounds, maybe 20 pounds.
All right. So this actually blew my mind when I was doing the research. Mm-hmm. So the largest fibroid ever recorded in history, are you ready for this? Mm-hmm. Is 140 pounds.
Oh my God.
Right?
That's insane.
It was removed from a woman in Singapore in 2014. I can't even imagine that. That's the size of a full-grown person.
I can't imagine how this poor woman was carrying this thing around. That's mind-blowing.
That's right. So how do you know you have a fibroid? Well, if you have a fibroid that weighs 140 pounds, I'm pretty sure that you would have some symptoms.
One would
I
guess.
know it, but most people have fibroids and they do not have symptoms. I should be clear. When I say most people, I would say most of our patients in the fertility world.
Yeah.
In reality, women who are not trying to conceive, who are presenting with fibroids, they usually are symptomatic, and that's why we're finding fibroids in them. But in the fertility population, when we're doing baseline ultrasounds and sonos to address your fertility potential, we do see a lot of fibroids that are completely asymptomatic.
Now, for patients who are having symptoms from their fibroids, probably the most common thing would be heavy menstrual period or heavy menstrual bleeding. Okay, so what's a heavy period? And we did go over this in episode 2 where we talked about the menstrual cycle, but again, always good to kind of
Go back down memory lane.
Yeah, exactly. Now, a heavy menstrual period would be something where the period you're needing to wear a pad and a tampon, you're wearing double protection, or you're needing to get up at night to change protection. You can't sleep through the night, or you're changing protection, let's say every 2 hours or something like that, because you're soaking through either a pad or a tampon or filling a cup. Or if you're using more than 21 pads/tampons over the course of your menstrual period, or if you're having symptoms from heavy periods, meaning that you're actually anemic. These are all signs of heavy periods. So along those lines, with fibroids, you can also have a prolonged menstrual period. So again, something that's lasting greater than 7 days of bleeding. Now, depending on the size of the fibroid, the type of the fibroid, the location of the fibroid, some people will also have pelvic pain or pelvic pressure, or you can actually feel a firm, hard mass in somebody's lower pelvis or abdomen. Along those lines, people will have frequent urination because of their fibroids, difficulty emptying the bladder. Again, depending on the location and the size of the fibroid, constipation can also happen, or having backaches or pains or shooting down the legs.
Like I mentioned before, in our patient population, which are people seeking fertility treatments, the fibroids are commonly diagnosed just in a routine pelvic ultrasound or a sonohistogram. So this is still the best diagnostic tools to identify fibroids. Every once in a while, you might need to do an MRI for a fibroid, but that would be in specific circumstances. The standard treatment for diagnosis of a fibroid would be a pelvic ultrasound, and then a sonohistogram would be to assess if a fibroid is growing inside the cavity of the uterus or not, which we're going to talk about next.
All right, so fibroids, they can cause all these symptoms, they can cause these problems, but why do they matter, or how do they matter in somebody's fertility journey? Fibroids can impact fertility in several different ways, but it really kind of comes down to location. So when we're talking about fibroids, it's all about location, location, location.
That's right. You sound like a real estate agent. Are you a real estate agent or a fertility specialist?
A little bit of both. I secretly love looking at real estate listings and watching real estate reality TV shows.
Okay, the truth is out.
Selling Sunset, oh, guilty pleasure.
All right, what are the types of fibroids? Joking aside, the location of a fibroid is really important. One type of fibroid called a submucosal fibroid is a fibroid that is growing inside the cavity of the uterus, right where the embryo may implant. So because of its location, this particular type of fibroid can actually have a detrimental or a negative impact on implantation, and depending on where it is within the cavity of the uterus, it can also cause distortion on the endometrial cavity and even potentially blocking entrance to the fallopian tubes.
An intramural fibroid is a fibroid that's growing within and it's contained within the muscular wall of the uterus. The uterus is a muscle. It has really thick walls that are really thick muscle. And so you can have a fibroid that's contained within the wall of the uterus as well. Now, with intramural fibroids, the impact on fertility is a little bit less clear, but if they get really big, they can distort the cavity or impinge on the cavity of the uterus. And depending on their location, they can actually block the entrance to the fallopian tubes. Or potentially, if an intramural fibroid is low down in the uterus, can also block the cervix and potentially cause issues for pregnancy and childbirth.
Another type of fibroid is the subserosal fibroid. This is a fibroid that is growing from the wall of the uterus, but completely outside of it. So it's not in the wall and it's not inside the cavity. It's outside the cavity of the uterus. Subserosal fibroids generally do not have any impact on fertility because they're not distorting the cavity of the uterus. However, depending on the size and the location, sometimes they can make access to the ovaries difficult during an egg retrieval. They can make vaginal delivery difficult if they are blocking the entrance to the birth canal, or they can also cause distortion with the fallopian tubes if they are located in a site where they're moving the fallopian tubes in a position that doesn't make them likely to pick up an egg and carry forward a fertilized embryo.
There's also something called a pedunculated fibroid, which is like a subtype of subserosal fibroids where they're attached to the uterus, but they're there by a thin stalk. So they're coming off of the surface of the uterus, but there's just that stalk kind of connecting them to the outside part of the uterus. We talked a lot about location being important, but it's also important to note that the number of fibroids somebody has and the size of the fibroids matters as well. And that even though we've classified them neatly into these 4 categories, in reality, fibroids can be a little bit of column A and a little bit of column B. So what I mean by that is that you can have a big fibroid that's partially submucosal, partially intramural. And this is where the nuances of fibroids and managing fibroids and their impact on fertility really comes into play. So even though we have these 4 cute little categories, it's not always so neat and tidy. And so there are actually more elaborate grading systems and schemes that we use to grade fibroids.
We look at a number of studies in preparation for this episode, and there is quite a bit of evidence when it comes to the impact of fibroids and fertility that supports what we just talked about the importance of location and size of fibroids. For example, there was one study published in our favorite journal, the Journal of Fertility and Sterility. It was a retrospective study looking at fertility outcomes between 2 different groups. One group was 88 patients that had uterine fibroids, and within this group, they divide them into subserosal, intramural, and submucosal, and they compared that with 318 patients going through ART as well that did not have fibroids, and of course, they were matched for everything else that matters, like age, BMI, and other fertility-related criteria. The study found that pregnancy rates per transfer were very similar in the group of patients that had subserosal fibroids compared to the group of patients that did not have fibroids at all. So this is to reiterate what we mentioned, that subserosal fibroids generally have no impact on pregnancy rates at all. When it comes to submucosal fibroid, which are the fibroids inside the cavity of the uterus, the pregnancy rate was only 10%, compared with a pregnancy rate of 30 and 34% in patients that had subserosal fibroids or had no fibroids at all. So significantly reduced pregnancy rate in patients that had submucosal fibroids. When it comes to intramural fibroids, there was also a decrease in pregnancy rate, although it wasn't as pronounced as fibroids that were submucosal. So the pregnancy rate in patients that had intramural fibroids was 16%, compared to 34% with subserosal and 30% in patients that did not have fibroids. There was another study that looked specifically at intramural fibroids and whether or not they have an impact on pregnancy rates. And this study looks at 94 patients that went through IVF and ICSI and divided them in groups depending on the size of the intramural fibroids and how far away from the cavity they are. And the study found that the pregnancy rate in the control groups, is that people who did not have fibroids at all, was very similar to the pregnancy rate in the people that have fibroid, as long as the fibroid was more than 5 millimeters away from the endometrial cavity and measured less than 6 centimeters. So as we were mentioning before, it's not just the location of the fibroid, but it's also the size. So with intramural fibroids, that's what we're talking about, the nuance of deciding whether or not they impact the cavity. It really relates to how far away they are from the endometrial stripe and the actual size of them.
So we've talked a lot about fibroids and their impact on fertility. Next question, of course, is how do I get rid of fibroids? Because they're not helping my fertility. They might be having a negative impact. So how can we get rid of them? That's a bit of a challenging conversation, and that's a bit more of a nuanced discussion. But really, the treatment for fibroids or how we deal with them depends on their number, their size, their location, the symptoms that a patient might be experiencing, and then, of course, that patient's desire to maintain fertility or at least keep that door open. So options for treating fibroids or managing fibroids might include things like medications. For instance, there are certain drugs like gonadotropin-releasing hormone agonists or GnRH agonists that can shrink fibroids, but are typically used short-term, maybe 3 months, maybe 6 months. And the decrease in size may only be like 10% by volume. So it's not a massive reduction in size typically when we're using a medication like that. There's also non-surgical procedures to manage fibroids. There's uterine fibroid embolization, which can block the blood flow, block the artery to that fibroid, which can cause it to shrink. When the blood supply decreases to a fibroid, it can become necrotic, it can essentially start to die off. And when that happens, it sort of becomes this soft, mushy mess, and it can come out vaginally in someone's menstrual period. Now, the challenge is that this is really not ideal for women who are considering having a pregnancy in the future because it can affect blood supply to the uterus, which is not ideal. Now, if somebody has had a fibroid embolization before, it doesn't mean that they can't get pregnant. It just means that it might make things a little bit more complicated, more challenging. The other thing is that this doesn't work for all types of fibroids or all sizes of fibroids. It can't be done for somebody who has multiple fibroids. The mainstay for managing and for treating fibroids is surgery. Surgery to remove fibroids is called a myomectomy. And this is often the preferred option for women who want to preserve their fertility or who want to have the option of getting pregnant.
Now, there's different ways that one can approach the surgical procedure. As Dr. White mentioned, the surgery to remove a fibroid is called a myomectomy. Depending on where the fibroid is located, we will determine the type of surgery that you would need to remove the fibroid. So if you have a fibroid that is located inside the cavity of the uterus, then we would perform something called hysteroscopic myomectomy. That means we go through the cervix, we put a camera inside the uterus, and use a loop at the end of the camera to cut away pieces of the fibroid and remove everything through the cervix and the vagina. This type of surgery is called minimally invasive surgery. It's done in the operating room. Patients do not have to stay in the hospital overnight, and they're not cut in the abdomen at all. And again, the ideal candidate for this would be someone that has a submucosal fibroid. If the fibroid is intramural subserosal, one can do what is called a laparoscopic myomectomy. That means that we enter through the abdomen through tiny little incisions, put a camera inside the abdomen, and then look around, remove fibroids that way. Laparoscopic myomectomy is a great technique. It's also minimally invasive. It also does not require a hospital admission overnight. The incisions on the abdomen are very small. And whether or not we can do this depends on the position of the fibroid and the size of the fibroid, because it needs to be removed through a very small incision. So if it's a very large fibroid, it might not be possible to do that. And last but not least, we have what is called a laparotomy or open myomectomy. And that means making an incision in the abdomen. It could be a horizontal incision or a midline incision, depending again on the size of the fibroid, and then removing the fibroid from the uterus, putting the uterus back together. And in this case, the patient does need to stay in the hospital overnight because every time that there is a big incision in the abdomen, it requires a bit more monitoring in the first 1 or 2 days after surgery. I think it's important to know that sometimes when a myomectomy is performed, regardless of the type of myomectomy that is performed, it might be necessary to do a cesarean section once pregnancy is achieved. It's not all the time, but that's something that your surgeon will discuss with you. And this is because once you cut into the uterus, you cut that wall of the uterus, it becomes a bit weakened, and as a pregnancy is established and the baby grows, and especially during labor where the wall of the uterus is contracting, if there was a prior myomectomy or a prior incision in the uterus, it might not be strong enough to undergo the contractions and it can rupture. Uterine rupture is a very serious complication of pregnancy. So for anyone that had a myomectomy, it is a discussion to have with the doctor that performed the myomectomy as well as the obstetrician following that pregnancy. Some fertility specialists do surgeries such as myomectomy, and some fertility specialists refer their patients for any surgical procedures. Here at Markham Fertility Center, we are affiliated with Markham Stouffville Hospital, and we're able to utilize our time. So we're able to perform our own hysteroscopic myomectomies, but we do refer to our trusted colleagues here at Markham Stouffville Hospital for more complicated surgeries such as open myomectomies or laparoscopic myomectomies.
All right, so now you've, let's say, had your surgery to remove the fibroids, your uterus is looking perfect. After the procedure, after how long can you resume fertility treatments or trying to conceive naturally? And so the time frame really depends on the type of surgery and individual healing. Generally, after a hysteroscopic myomectomy, you can probably start trying to conceive or start fertility treatments within just a few menstrual cycles. If you've had a laparoscopic or an open myomectomy, surgeons will often recommend waiting anywhere from 3 to 6 months to allow the uterus to heal properly. With surgeries, there are lots of potential risks. So it's not just the procedure itself and the risk of anesthetic, but there's long-term risks to fertility associated with all of these types of surgeries. Anytime you're doing surgery, there's a risk of causing scarring in the uterus or damaging the uterus itself. Scarring in the uterus has a fancy name, also called Asherman's, and it can be a really difficult problem to solve or to overcome in the world of fertility. And with all of these types of procedures, the risk is not small to create that scarring, and that could mean that you need to have more surgery or subsequent surgeries. With these surgeries, when you're cutting into the wall of the uterus, you're creating these weak points on these scars in the uterus. And those can all cause issues as well in terms of implantation and contraction of the uterus. The other point that's important to make is timelines and how long it takes to be seen by a surgeon, to get the surgery done, and then to recover from surgery. When we're thinking about fertility, we know that time is of the essence and that sometimes for some patients, the clock is really running or even running out of time. And so we have to take all of these things into consideration when we're thinking about whether somebody should proceed with surgery or not.
It's important to know that during the IVF process, which is taking the eggs and sperm, fertilizing them, and creating embryos, fibroids are not usually a problem. What I mean by that is we're not using the uterus in an IVF process, and we're not necessarily doing an embryo transfer during an IVF process. So because of the timelines and because of the impact of age and fertility, if you have a fibroid that we know is impacting implantation, you can still do IVF, take the eggs out, make embryos, freeze embryos, and then worry about having the myomectomy or the fibroid removed and doing an embryo transfer down the line without having, quote unquote, wasted those precious months or years that it takes to carry forward with a myomectomy and the recovery. Every once in a while, a fibroid can actually have an impact on the access to the ovaries. So in this situation, then we wouldn't be able to do a retrieval at all until the fibroid is removed, but that would be very rare because ovaries can be accessible both vaginally and transabdominally. And here at American Fertility Center, because we have anesthesia, we're really able to sedate our patients very well and get very good access to the ovaries, even in situations where it might not be otherwise possible if patients are not well sedated. So what happens if someone gets pregnant while they have a fibroid? This is a very common scenario actually in the fertility world because like we mentioned earlier, many of our fertility patients have fibroids that they didn't even know they had until we're doing a fertility assessment. The vast majority of patients who conceive while having a fibroid do really well in pregnancy, and the fibroid has no impact on pregnancy whatsoever. Sometimes fibroids can actually misbehave during a pregnancy. And some of the things that can happen is, for example, a fibroid can be very big and it can be preventing the baby from engaging and turning headfirst into the birth canal. So a baby could become breech, or a baby might not be able to pass through the birth canal because of a large fibroid blocking it. And therefore, there would be a situation where a fibroid would impact pregnancy in that you would require a cesarean section. Another thing that can happen with fibroids in pregnancy is that the body's smart and puts the blood supply where it should go, which is towards the baby and away from the fibroid. So fibroids can get very jealous of that blood supply and very angry and become necrotic because you're not getting the blood supply anymore. So a fibroid that is necrotic and dying can be very painful. Sometimes patients have to be admitted to hospital for pain management. Sometimes you may develop a bit of a white count or a fever because the fibroid is throwing out a lot of inflammatory markers as it is becoming necrotic. And this is a situation that, of course, is very scary and difficult for patients and obstetricians because you cannot just go in there and remove the fibroid while there is an ongoing pregnancy. So it would require careful observation.
Surgery does not come without risks, though. And I think this is a really important point to highlight. It almost sounds like it's a no-brainer that if you have a fibroid, you should have it removed pre-pregnancy or pre-fertility treatment to maximize your odds of success. But it's not that simple.
Nothing in our world is simple.
Very, very true.
Sometimes I crave simplicity.
I hear you.
So when it comes to fibroids and pregnancy, I have seen situations where, let's say there is a bad pregnancy outcome, let's say it's a second trimester miscarriage or 1 or 2 first trimester miscarriages. There is also a fibroid. And I understand that it's very hard for patients sometimes to not have that fibroid removed because they had the bad outcome and they have the fibroid, and it's very easy to blame the obvious thing in front of us. This is a discussion to have with a fertility specialist and a gynecologist because, like we were mentioning before, doing a myomectomy for a fibroid, regardless of which type of myomectomy you do, is not without risk, which Dr. Weiss went into those risks really well. Like everything else in the fertility world, it really requires looking at the pros and cons, the potential risks, the potential gains, and having an honest conversation with your doctor about what that may look like and what you're able to tolerate as a patient in terms of fertility outcomes. Hey, do you know that some of my patients actually name their fibroids? And I think it's really cute. I love it. And then we talk about the fibroid like it's a third person on their journey.
I like that, taking ownership of it, or talking about the impact of it.
I had a patient actually with a very large fibroid, and we had this discussion that we're talking about, do we do a transfer? It wasn't in the uterus, the risk of myomectomy. So she decided to go ahead and do a transfer, and she got pregnant, and now she had a name for the fibroid and a name for the fetus that was growing inside of her. And we had great fun talking about both of these people that were in her abdomen.
So I'm going to try something a little bit different for today's episode.
Oh, I'm scared. Did we talk about this beforehand?
It's okay. You're going to be fine. Okay. So we're going to end this episode with a joke.
Oh, boy.
Okay. I got a joke for you. I'm very proud of this. Okay? All right. Why did the fibroid get invited to all the parties?
I don't know. Why?
Because it really knew how to grow on people.
Oh, my God. You're so tricky. But I love you.
So if you enjoyed today's joke, please let us know on our social media accounts on My Fertility Podcast on Instagram.
But maybe don't encourage her too much.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.